Well, thank you very much. This is my first trip to Mount Sinai, but it was nice to reconnect with Dr. Ofsis a little earlier today, because I remember very much when I was a resident and he came as a visiting professor and told us all about his experience at that time with inflammatory bowel disease, and I got a chance to make rounds with him. And just was really impressed by what he had done at that time. And obviously the tradition continues over the years, and it's nice to see that. It's really an honor and a privilege to be here. I didn't know of Dr. Breyer, but from what you've told me, he certainly sounds like a person that we would all want to emulate in what he's done. So it's really my pleasure to be here and give this lecture. So I don't have any disclosures. I don't get any industry funding for this. I'm going to try and address four things here as learning objectives. We're going to talk a little bit about the challenges of the current educational environment for residents, recognize how we might assess competence and foster confidence in residents, and then talk a little bit at the end about education and quality and how those two concepts really merge, and I think is really they just are really equivalent. I mean, we can't have good quality without good education, and certainly the reverse holds as well. So a little background information. I think we all understand that the traditional surgery residency was established a long time ago. Its goal initially was to train teachers. It had a very well-defined structure, and included in that structure was an emphasis on clinical practice, which was a change from what had been done previously. There was a graduated responsibility, and the key, I think, was this year of so-called independent practice, while still under the umbrella of a residency training program prior to completion. And I think we all know about the monastic characteristics, most of which have been shed by now. So if we fast forward more than 100 years later, what's happened? So residency now has a defined duration. It didn't always used to be that way. Autonomy is less. There's been an impact because of the growth of information that's out there that clearly, I think, has had an effect on confidence. And I'll try and make that point a little later on. Society has changed. The public expects more from us as physicians. We're certainly into politics. That's how we got duty hours. And social values have changed as well. So there are clearly different expectations of all of us, not only as trainees, but as physicians and surgeons in practice. And of course, we have the duty hours requirement, which has changed the landscape. If you think about the continuum of professional development, and I hope this slide illustrates what happens over time, we really begin our training in medical school with a very high degree of supervision and not much, if any, authority. And then this changes over time, and the authority increases and the supervision decreases. So what's the problem? I just want to go into a little bit of definition about competence and confidence. So these are some definitions of competence that are in a dictionary. Do you have suitable, requisite, or sufficient skill, knowledge, or experience for a purpose? Competence has been defined as being properly qualified and adequate, but this is the key, but not exceptional. Okay, adequate, but not exceptional. I like this definition that really comes from the organizational development literature, which is a capability or ability that distinguishes effective performance. It doesn't say anything about experiential learning. It really emphasizes effectiveness. And so it gets us beyond, what's competent, what's proficient, what's adequate, what's not. So good definition there. Confidence, a little different. It's trust. It's about belief in one's powers, trustworthiness, or reliability, or belief in an other person's characteristics in that regard. Certitude, if you want a one-word definition. And it's really got two components. It's self-confidence and it's how others view you and what confidence they may have in you. So, do we have a problem? Well, I'm going to pose a number of different surveys, primarily that suggest that we do, and then provide some data that may reinforce what the surveys tell us. So this is the first survey that appeared regarding this issue in recent years, and it was from the American College of Surgeons Board of Governors, and about 200 respondents, and there were a whole variety of questions about practice, but this one and the next one I'm going to show you are really about the practicing surgeon's opinion regarding residency training. And this was the question asked is that was there, in the current training system, do chief residents graduate with gaps, significant gaps in their education? And you can see here about 75% said yes. There were a smaller group that weren't really sure, and only a minority, about 12% in this situation, said no. So the next question the governors were asked was, well, what's the gap? What's the problem? And they defined this as technical skill and decision making. Okay. Now, this is the notorious Fellowship Program Director Survey that was presented at the American Surgical Association a few years ago, and then published last year in the Annals of Surgery, where another survey was done of fellowship program directors. And this was a wide variety of backgrounds, some of which were minimally invasive surgery. In fact, most of them were involved in minimally invasive and bariatric surgery, but there were some in colorectal surgery, a few in thoracic, some in endocrine surgery. It was a real mix, if you will. And when they were asked to evaluate professionalism at the initiation of fellowship training, they said professionalism was good. So, you know, we seem to be doing a good job of training residents in that regard. Can residents operate without supervision? Well, this was a mixed bag. And many of them said that the residents couldn't do even something as basic as a laparoscopic cholecystectomy. And remember, that's the most common operation done in surgery residencies. And if you look at the average done throughout the country, it's about 100 or a little more than 100 by every graduating resident. So this is a common operation, a lot of experience, and yet their decision was, well, we can't trust or have confidence that these individuals can do that operation without our presence for a short period of time. Now, one can argue with this. I certainly don't think that it's accurate. But again, is there some observer bias here? Is this a representative group that of residents that were being compared to others? Were the expectations high? We really don't know that. And when they evaluated psychomotor skills, there was a concern that was expressed as well. So another indicator of a problem. Let's look at this from the other point of view. So this was a survey done by Mark Friedel, presented later that same year at the Southern Surgical Association. It was in 2013, and then published this year, now back in the spring. And in this situation, Friedel, through the APDS, began to ask a question about level of comfort. You could equate that with confidence. But he asked it in a different way. And he looked at it in a number of different operations. And if one looks at the scale here, these are the operations on the left side that are done more commonly. And you can see here on the right side operations that tend to be done less commonly in most residencies and have a high degree of difficulty and complexity associated with them. Whipple procedures, liver operations, esophagectomies, et cetera. And you can see that if you look at comfortableness or confidence in this case, the common operations, the residents seem to be very comfortable doing. And not surprisingly, when they begin to evaluate their level of comfort in doing operations that they do less frequently, they aren't as comfortable. And that's probably not a characteristic that's bad. It's probably a characteristic that we would all think is really pretty good. You know, you ought to be concerned if you don't do something very often and you're put in the situation where you're asked to do it. Different survey, again, of residents, highly selected, done the year before the Friedel survey, and in this question, there are a lot of questions in this survey asked of residents over the course of training. You can see a lot of different respondents over time. And this was the one about, you know, what is your do you have a high level of confidence in your ability to be in independent practice following residency? Well, not surprisingly, most of the PGY ones didn't feel very comfortable that they could go out and practice immediately. No surprise there. And this got better over time, which it should. But once again, you're looking at about 25%, roughly, maybe a little less than that, of graduating residents in this survey who don't feel confident. Now, what I'm always impressed with about these various surveys is thinking back to that first one of the fellowship program directors. It was about 25% of people who felt that the confidence and competence weren't good. The Friedel survey, not much different. This survey, not much different. So again, we've got this continuous reinforcement from a variety of different arenas that tell us that about a fifth to a fourth of our residents may not be as confident or as competent as we think evaluators from the outside should be, or perhaps as they might feel or wish to be. Now, here's some hard data. These are board exam failure rates. Okay, and this is cumulative information over time. You can see this goes back to the early 90s. Big drop off here. We're not going to talk about why that happened, but this is when I started on the board, by the way. It was right about here. So things got better then, I guess. I can't take any credit for that. But what happened over time is really this isn't too far off of a straight line. Over about 15 years or more, the failure rate on these exams has stayed the same. There's obviously some concern here about this uptick in the failure rate on the oral examination. And by the way, if one continues these out into 2013-14, last year's data, there isn't a lot of difference here. Actually, the qualifying exam pass rate has improved. The failure rate has dropped, that is, so to about 18% over the last 2 years. But the oral examination has stayed in about the 20 to 22% failure rate range. So there's a concern that that may be representative of whether or not residents are competent or confident. Now, remember, this is an artificial situation. I don't think any of us would look at a recollection of our board examinations as being totally reflective of what we did in practice. It's clearly a different situation, but if one puts credence in this, it suggests, again, that 20 to 25% number keeps coming back. This was an interesting report that came out of Johns Hopkins Hospital that examined their own residents over a period of time and compared a resident's self-evaluation of their level of performance with peers, with nurses, and with faculty evaluations. Okay, so this is sort of head-to-head. What do I think about myself, and then what do you think about me? And this is an interesting figure because what it does on the left side, it shows you the people in the program that were judged to have the lowest, be in the lowest quartile of performance, and on the right, the individuals in the highest quartile of performance. So these were everybody thought these were the great residents over here on the right and the not so good residents on the left. And clearly the difference in their residents' perception of their own abilities and others' perceptions of their abilities in that low-performing group is really a lot greater than in the high-performing group. So people who tend to be in that high-performing group actually have a lower degree of self-confidence. And is that earned or not? I mean, others obviously don't think it is, but I think the concern here is that, you know, are these people overconfident? And overconfidence can be a bad thing, I think, as we all understand in surgery. Well, what about self-confidence? Does it make a difference if you're confident in yourself or not? Well, it's clearly a key factor in resident attrition. Okay? And by the way, resident attrition is greater among women. And as we see more and more women medical students, more and more women pursuing careers in surgery, this is going to become an important issue because women rate themselves as less confident, and that's just not in surgery, by the way. That's an observation across all disciplines. Women tend to be subject to what is called prescriptive gender norms. Most of us understand that as sex bias. It's a simple term. Clearly, women are more affected by dismissive behaviors, and I think this is an important fact to realize. So what some of us may do in attempting to be critical of our male residents is taken in a very different way by women. Same behavior, different way. And women are often viewed in subordinate roles. So I can't think of a time, and I suspect most people can't, when they've been making rounds in the hospital and someone will mistake, or intentionally or not, a woman resident for a nurse, okay? Because it's the thought is, well, women are nurses, right? And some people can't get past that. So a lot of things may affect self-confidence. Well, what about competence? Well, in competence, there don't seem to be those gender differences. Competence often reflects observer bias. So it's what our values are that impacts all of this. It clearly can vary among individuals. So each of us may have a different perspective of what competence is and a different definition. And there's clearly a halo effect, right? So when a resident comes on your service and you've been told that this is the greatest resident in that particular group or the greatest resident we've had in the last decade, I mean, you know, they're walking in already with this tremendous track record, and that is going to affect, it always affects our judgment of those individuals. Well, there are also some evolutionary changes that have occurred that I think impact this whole issue of confidence and competence. We clearly see different diseases now than we did in the past few decades. The intensity of illness is increased. Disease management is changed. Oftentimes the therapy have changed. Our role as surgeons in treatment of many diseases has changed over time. So we have that to put into the equation, as well as the experience has changed. And I'll show you some data on that in just a moment. We all know that there's increasing subspecialization. That's got a good and a bad part. We'll talk about that some more. Knowledge has expanded. Autonomy is down. It's very difficult to find a situation anymore where a resident is truly autonomous in what they do. And clearly there are changes in expectations that have occurred as well. And those changes, I think, are not only what society sees or the patient sees, but there clearly are changes in expectations of the learners, the residents in this case, and the teachers, that is, the rest of us. And I think one of the key problems here that just goes back to something that we all would recognize, and that is, have we failed to adapt? And is that really what the problem is? So change has occurred forever and will continue to occur. And the real key is, can we adapt to it? Well, what about expectations? I think sometimes the expectations of our residents, it can be a little bit perhaps beyond what is real. One asks about some of the characteristics of general surgeons. We can identify with characters in fiction and otherwise that are portrayed as being the ultimate. Notice, by the way, the heavy impact on men in these photos. And it's very hard, by the way, when you want to try and find an example of this. You know, you go to Superwoman and you get a very different set of images than you do at Superman. So that's why we stayed with this. And the other thing that's happened too is, are our expectations really too high? Do we expect everybody to be that genius? Or this is the ultimate in expectations? Is this what we expect out of our graduating residents? Or is this more representative of the master surgeon, if you will, the individual that's been in practice for decades and clearly is this font and resource of information and experience that we all treasure? There are ways to evaluate training programs across the board, whether it's a residency training program in surgery or a training program in some other discipline, and this is has been developed by Kirkpatrick, and the reaction from the trainees should be positive. There should be some way to measure learning, and we do that by assessment of knowledge. We want to look at behavior, and that's application of the training program to its end result and its purpose, and also to look at the outcomes. Well, what's the reaction? If one looks at match data from this past year, high degree of categorical positions filled. Okay. The attrition rate we know from past surveys is about 3% per year. By the way, that people look at this and they come up with this cumulative rate of attrition by multiplying. And they say, well, the cumulative rate, if you put this all together, turns out to be about 18%. And that's really not true. So be very careful. This may sound like simple math, but it's not. It's actually, you have to compound that over time. So the 3% actually drops each year. And it's really closer to an attrition rate of about 11% rather than 18%. But still, I think we would all agree higher than we would like. If you ask residents that complete surgery, would they do it over? They say they would, and the same thing is true for practicing surgeons. That's not uniform, but certainly the overwhelming majority feel that way. And the evaluation of trainees about the quantitative and qualitative aspects of the residency programs is really quite high. Now, what about learning assessments? Well, we've got a number of those. Clearly there are some formative assessments like the ABSITE and the self-assessment tests on the SCORE web portal. We rely very much on faculty and program directors to give us an assessment of the ability to translate medical knowledge and operative skill to practice. We don't have a good way of assessing that, so we rely on all of you to do that for us. And there are some other evaluative tools, the qualifying exam and the certifying exam, information which I showed you just a little bit ago. Well, what about the experiential aspects of this? So we've got an operative case log, so we don't have a great identifier for experience and competence in an operation, so we tend to count cases. And we look at the breadth as well as the frequency of exposure. We really have very minimal measurement of non-operative case experience, and so we rely on these surrogate measures for overall competency. And we've tried to identify better markers of competency than we've had in the past, and we call those now the milestones. Okay? Something that we're now beginning to assess in residency training programs, and we'll see how that turns out. So this is a table that came from an article published by Dick Bell in 2009 that looked at the 2005 graduating resident experience. So now this is about 10-year-old data. And if you think that a frequency of doing an operation 10 times is about the right minimal experience, and that's what was assumed when this was done, so that's the bar right here. If you look, that only happens in about 20 operations that residents do. Okay, and these are all classified, by the way, by CPT codes. Okay, so there are about 100, a little more than 120 roughly operations in here. And you can see the frequency very high. This is lap chole, as I mentioned earlier. And then you can imagine what's out here. A lot of complex, infrequent operations that tend to be done in very highly specialized centers. And remember that most residents don't train in a program the size of this in a community as large as this with the complexity of what you see in your training program. So this is really the breadth and the spectrum of surgery residency training. Well, we updated this information with the experience of 2010-11 chief residents, and we looked at them according to what then became classified as the SCORE operative categories of essential common, essential uncommon, and complex, and looked at the frequency. If you look at the number of operations done at least 10 times, it hasn't changed. It's still that base number of 20 different operations, and then you can see many of these so-called common operations aren't very common. In fact, we have 4 of those essential common operations, of which the median done across the country was 0. If you look at essential uncommon operations, we got that right. They are uncommon. Okay? So about 66 operations in that category, most of which are done less than 5 times, and many of which are not done at all. And if one looks at complex procedures, we didn't count the nevers in here, by the way. It was a large number. But you can see complex procedures, by and large, tend not to be done very frequently also. So one has to begin to look at the overall experience, and do we begin to view general surgery as restricted to those very commonly done operations as we count them, or is it broader than that? And that's a debate that I think continues to this day and will continue for a while. Now, another interesting study that Bell published the same year was about resident learning needs in the operating room, and just on a survey of residents and faculty, compared the residents' perception of what they wanted to learn in the operating room, which you can see here are very technical. The residents wanted to learn about instruments and suture material and exposure, putting the patient in the right position, and how the operation should go, and the faculty had a different perception. So they were interested in teaching things like anatomy and disease processes, and talking about complications and risk and what do you know, et cetera. And it really took until you got down to number 5 on both lists to where there was agreement. So we've got a mismatch here. We've got a problem, Houston, right? Okay, we've got one group that thinks this is what they ought to be learning. We got another group that thinks they ought to be learning something totally different. So we need to somehow bridge that gap. Can we accurately measure operative skills? Well, we have a variety of ways of doing this. One is direct observation. This is kind of time-honored and goes back for forever. We have indirect observation, so one might review a video. If you review a video done through a scope, you see one aspect of what goes on during an operation. Very different from direct observation, where you have a chance to integrate everything that goes on in the operating room and the effect of the overall team's approach to the procedure. And lastly, we have simulation, whether it's in one of the ACS accredited education institutes or not, but another way to make an assessment. The real issue here, I think, comes up when we look at the 4 R's, and that is based on whatever method we use to assess skill, what's our recommendation, and what do we do in the case of adversity? So what do we do when there's need for remediation, restriction of privileges, or even the worst thing that happens, revocation of privileges? This may be more affecting surgeons in practice than residents, but it really is a continuum, you know, as to what individuals do. And I think this will become more important as we begin to move towards competency-based training, where you'll have to meet a certain level of expectation in order to, you know, if you will, be able to check that box on what you do. A little bit about experience. You know, there's the 10,000-hour rule that I'm sure you're well aware of. It was popularized by Anders Ericsson, shown here in this photograph, but really popularized by Malcolm Gladwell in his book Outliers. And if one looks at surgery residency and tries to apply that 10,000-hour rule to surgery residency, and this is a rough calculation using the 80-hour work week, figuring you get 4 weeks off a year, you work for 5 years, and then, oh, by the way, not all of your rotations are surgical, so we put in a little fudge factor here. It's clearly over 10,000 hours, but the real issue here is this deliberate practice. And there's good information that suggests only about 20% of an overall resident's time is spent in the operating room. So that's not 80 hours a week. That's closer to 15 to 20. Okay? So if you calculate that, we clearly haven't hit that 10,000 hours, which says that we're a little bit short of what the experiential need is. Well, this is an old saw that I think we're all familiar with. We talked a little bit about this at the dinner with the residents last night, and it's good judgment comes from experience, and experience comes with bad judgment. Who hasn't had that affect them in their careers? A little bit about duty hours. What's happened as a result of duty hours? A lot of things have occurred, but I think these are facts that are very clear. And have been reported by ACGME in this publication by Philibert, as well as recollected in this publication in JAMA Surgery. We know that resident working hours have decreased. Okay? They didn't used to be 80 hours, so they're less now. There's clearly improvement in resident mood and less resident burnout. We know with the recent implementation of the 16-hour rules for the PG1s that there's reduced operative volume in that year. We know that continuity of care has diminished. Educational continuity is less. And why is that? Well, because not all the residents are always there because of some of these restrictions in the duty hours. There clearly have been differential effects on patient care. I'll show you some data again in just a bit. Negative effects on professionalism, and a decrease in experience with emergent conditions. So what's tended to happen is we've contracted to 80 hours is residents take less call. Okay? They do fewer emergent operations because most of those operations aren't done in regular elective hours. They tend to be done nights and weekends. That's where the preponderance of those cases has tended to lie. So the experience with those types of procedures, which often require complex decision-making, okay, as well as a higher level of intensity of care, that experience has dropped. And we now have a much more focused elective practice experience. So think about how that may begin to impact on competence and confidence, and how that also might impact on what most of our residents are choosing to do now at the end of their 5 years of training. That is, they want to specialize into something else. Well, this is another survey. Sorry to bore you with these. Actually done by a plastic surgery resident at Brown, Brian Drollett, who's actually done a lot of good work in this area about resident attitudes. And what he did is he surveyed residents in different disciplines, as you see here, and asked the question about duty hours, and that is, then this is sort of the roll-up about, are you accurately reporting your duty hours? Okay? And you can see here for all respondents here in the entire group, non-compliance, 53%, okay, with that, and individuals as well that false reported were 43%. If you look at the discipline, surgery was absolutely the worst in this particular circumstance, where more than 60% of the residents misrepresented what they were doing and what they put on the survey when you asked them. Okay? Now, that's a telling characteristic and suggests that we've defeated professionalism with this survey in what we expect of the residents and perhaps what they expect to do in this restriction in duty hours. And I think, you know, some of you are aware, I know this isn't happening in New York State, but right now there's an ongoing trial in surgery residencies comparing a control group that is the standard duty hours versus an experimental group, which is contracted to the duty hours restrictions to 3 things: 80 hours per week, 1 day and 7 off on average, and call no more frequently than every third night on average over the course of a month, with an idea to compare outcome results in those two groups after a year. We'll see what impact this has on, first of all, what the results are, and secondly, what our reaction is to those results, and whether or not that will have any impact on duty hours reform, going back, perhaps, if you will, swinging the pendulum in the opposite direction, yet to be seen. This summarizes a little bit of what I showed in that last slide, and if you begin to look at this 16-hour restriction, 17 programs, what they saw is that time in the OR was less when this happened. Patient safety, as it was measured here, more perceptive than actual data enforced, was less, and education and training was less. More information that really reinforces what I just told you. And this is another article that came out of from ACGME, actually, that looked at patient safety in a number of different studies over time, both in single institutions and national data samples, as to where patients did better with implementation of duty hours. This was the 2003 version of duty hours change, or did worse. And you can see here that, you know, most of the things that said patients did better were in the medical specialties, which are the tans, and where patients did worse was in the surgical specialties, which is in the blue. Notice that some of the investigators really were not different one to the other. There's a spectrum across this, so it's not any, I don't think there's a single answer here that one can say is definitive, but clearly there seems to be a difference between surgical studies and medical studies. I mentioned earlier the trend towards specialization, and we know that a lot of things happen with specialization. There are some good things that happen. Listed those on the left side of the slide, and there's some bad things that happen. We worry about fragmentation of care, uniformity of training, particularly for the non-accredited specialties, specialty trainings that are out there, and we know that the call responsibilities, I think in most institutions, can be challenging as specialists want to restrict what they take call for and sometimes don't want to take call at all. Healthcare delivery has changed as well, and we've gone from a very physician-centric view of healthcare delivery to patient-centric. It's more based now on evidence-based guidelines. Practice has clearly changed. We're looking at integrated systems of care and payment in the future rather than individual volume-based types of payments. We're all faced with trying to reduce costs and emphasize wellness and prevention rather than healing once the disease has occurred. So this will have an effect on what we do. Perhaps not in all areas, but it will have an effect. And I think what's really changed is the whole concept of the captain of the ship that the surgeon has always been likened to. And I would think of this as this was sort of the captain of the ship back when I was a resident. You know, you had complete control. You were in charge. You took that boat in the direction you wanted. And this is sort of today's boat. Okay? It's much more complex. It's integrative. You're relying on getting everyone to do their part to make this huge, complex organization work effectively for our patients. So as we look to the future, you know, what do we see? Is it cloudy? Is it bright? There are some improvement efforts that have already been put into place. A number of years ago now, almost a decade ago, the SCORE Council was formed, and it has now come together, defined a curriculum, which I think you're all aware of. We are trying to improve the efficiency of learning with a variety of efforts. We'll see how many of those go. Clearly, simulation was not that common 10 years, 15 years ago, now common in all residency programs. We're trying to provide operative experience earlier in training, and I think you'll see that now effective in what has been implemented by the board and the RRC, effective with this year's entering class. We're trying to find ways to restore advanced laparoscopy to core training, modify the training to accommodate career plans. So for individuals that have defined themselves as to what they want to do in specialty training following general surgery, we're trying to allow some flexibility in the schedule to give them some pre-experience, if you will, before they enter those fellowships, but yet maintain the core of what you need to learn in a surgery training program. So that's a tough assignment in a lot of places. And we want to improve quality and uniformity of that additional training as well. Have to have an advertisement here for the SCORE portal. Was happy to talk to some of the residents last night and find out that you guys are Uber users. And actually got a few good ideas about that I'm going to take back to our group about some things that we might do to make this even better. Well, what about improving experience? This is hard. Clearly, how do we increase exposure to a variety of different situations and increase the frequency of operations? I think this is going to be one of the challenges that we face in the next few years. Using simulation appropriately as part of deliberate practice outside of the operating room, and also not just to do things that we do frequently, but also to provide a platform to learn things that we do infrequently, so that when we are asked to do them, we have a pretty good understanding of, and memory at least, that we can recall and bring to light in those procedures. How do we analyze outcomes and compare these to norms is important as well. I mentioned milestones a little earlier. This is a new initiative now in place. A lot of places have put it into practice sort of as a routine up until this year. And the Residency Review Committee will now be able to see whether or not residents progress appropriately in a whole variety of areas that we don't currently assess very well at all. And by the way, there is no expectation that at the end of training, everybody is going to hit the highest mark in all of these areas. That would be the super resident. Those aren't always there. And you know, we're always going to have things that we can improve on. But the real question is, for areas in which you start out as a low performer, are you going to get better? And that's really what the RRC will be looking at. Just a few brief words about confidence and judgment. This is Mentor, talking with Telemachus, Ulysses' son. Back in Greek mythology, Ulysses, you know, took off and went to fight wars and do a lot of other things in his life for about 2 decades. And so he charged Mentor, his good friend, with bringing up his son, Telemachus. Hence the translation now of mentoring or coaching, and that's what Mentor was doing over that period of time. I think this is something that we don't give enough credit to, and will likely be something that we'll be exploring more and will come into play, not only in training programs, but also I think once residents enter practice, particularly in that critical first few years, 3 to 5 years entering practice, where we're going to try and find a way to link people up. Not an easy task, believe you me. It sounds really simple, but there are a lot of barriers to doing this. Well, what about residents and quality of care? Is there a relationship here? If you look at this study done of the NSQIP data, and you looked at resident participation, this was done by Vic Fazio and some of his associates at the Cleveland Clinic using the NSQIP database. Mortality didn't change if residents were involved. There was a slight increase in minor complications, basically wound infections, from 7% versus 6.2%, so not a great difference, but it was significant. And if you had a resident involved in the case, it took longer. So I don't think that last thing is a surprise to anybody. What about quality measures? I think if you put this into a checkbox form, outcomes with residents clearly are fine. I think we have good indicators that suggest that resident participation in care makes patient safety better. Our resource use could be a little different. That's the whole background of why the government provides payment for resident education. We probably need to improve our resource use, and clearly the patient experience of care is benefited by resident participation. So I just want to end with some do's and don'ts, and perhaps this is more for the faculty than anybody else, but I think we need to develop and implement objective measures of competence and achievement. We don't have enough of those now. We need to commit to faculty development. Can we be better evaluators of resident performance and resident competence? We need to recognize that learning is lifelong, and residency provides that foundation, that base of learning. Not only what is it that you need to know when you finish, but how do you get the information that's going to change next year from what you were taught the year before, because that's been happening now for forever. And I think we need to promote and recognize diversity in the surgical workforce as well as diversity in surgical leadership. Well, there's some don'ts as well. It's easy to assign blame. We're all very good at that, and we've got to resist it as much as we can. I hope none of you ignore your commitment to general surgery, because that's really what this is all about. Please don't accept that competence is unobtainable by residents. I think most of us don't feel that way, but occasionally that can happen. And don't confuse caution with lack of confidence. It's okay to be cautious. I would think that most surgeons are. Some of them may have a very short lifetime of caution that we see, but I think most of us are very cautious in our approach to what we do. And I'll leave you with this final thought about education in general, and I hope that all of you remember this and continue to light fires. And thank you again very, very much for the honor and privilege of delivering this lecture, and I'd be happy to answer any questions.